I would also like to acknowledge the traditional owners of the land that I'm on, which is the Gadigal people of the Eora Nation. And one of the things that I think why acknowledgements of country is so important, it's not just about acknowledging the continuing culture and struggles of our Aboriginal brothers and sisters. It's also reminding us of the importance of land, the importance of people, the importance of community, and the importance of elders and leaders. And so I would also, with that in mind, acknowledge the great work of the many people who have come before us in putting men's health on the map. And of course, there are many Indigenous men. Professor Mick Adams comes to mind, Jason Bonson and many others who have been working hard for Aboriginal men's health as well. So this is very exciting. Thank you, Glenn. Thank you, Men's Health Forum, for this opportunity. I think it is a very exciting and innovative way for us all to connect up when we can't connect up. And one of the joys of working from home, which is where I am at the moment, is that at some point during this discussion, I'm going to have to change rooms. So if my screen goes blank and I go on mute, don't worry, I'm still here. I'm just moving my computer. So I would like to start this conversation around men's health research by asking our 4 panelists, if you could please just quickly introduce yourselves and where you're working from and the particular areas of men's health that you've been involved in or you are involved in. And then we'll bring this together into a broader discussion about men's health and its importance and why we're all doing it. And so the order that I'd like to go in is with starting with Professor John Macdonald, and then going to James Smith, Professor James Smith, Professor John Oliffe, and then Professor Derek Griffith. And we'll, as I said, after these brief introductions, we'll then start a discussion with all the colleagues. So John, I'm wondering if you would like to please give a short introduction and let us know the particular areas you've been working in. And I suppose just in terms of full disclosure, as people who are on before 10 would know, there is a strong connection between all of the panelists at the moment. And John and I worked at the Men's Health Information Resource Centre at Western Sydney University for 14 years. And John was my PhD supervisor. So we've known each other for a long time. This is coming up to 20 years, John, since we've been working together. So with that in mind, John, please, over to you.
Okay, thank you very much, Anthony. Like everybody else, I'm going to say something about the acknowledgement of country. I'll say it very briefly, but it brings me back to some years ago in Canada, not John Oliffe's Canada, but in Quebec, where I go sometimes, where I'm part of a discussion on masculinité, société. That's another story. But I began, as we do in Australia, by acknowledging the traditional owners of the land. And for us, it's a kind of custom, and I hope it's more than just words, that we actually mean something. Interestingly for me, when I went back to Canada, to Quebec, it was opened by, the session was opened by an Indigenous man, a First Nation man, who said that they had learned from us in Australia, and I was quite extraordinary. I was quite extraordinarily pleased by that. Anyhow, my understanding of acknowledgement of country is that it's, for us here in Australia, it's embracing also the contradictions. We, mainly white men, are acknowledging the people that we have colonized and still do colonize. And I think that embracing of contradictions is part of what I would like to emphasize in my own presentation of my own work, that we accept the contradictions of who we are, often white middle-class men working in situations of diversity and even deprivation. Anyhow, that comes from me. My introduction would be, I used to live in Zambia, again, contradiction, a white man living in an African country for 10 years, and I learned many things. And one thing I learned, which I still carry with me, is that I went there with the idea that we were looking at the problems of the people, endogenous, as it were, things inside people. Whereas quickly I learned that often the problems are exogenous, they're from outside. And that's something I've kept with me ever since. When I came to Australia, also working with Anthony, as you've seen, as you've heard, I was interested that in question of men's health, let me just say, the way in for us was sometimes through suicide, sadly. Male suicide in in Australia is very high. And I was astonished when we looked at the research. We could find research on how men kill themselves through guns and through ropes, but why men would kill themselves? Why? Nobody seemed to be asking that question. And when people began to ask that question, the answers they often came up were endogenous, something inside men. Men were incapable of getting in touch with their feelings. Men were incapable of getting access to health services, etc. Endogenous. There was not a big look on exogenous things. And I've come over the time through not only, but also through a small study called Pathways to Despair, where we looked at the lives of men who had taken their own life, sadly, through their families and through the stories of men who'd made serious attempts. We called that study, which has been very formative for me, Pathways to Despair. And the word despair is important for me because I think one of the things I've done or I want to be part of is to demedicalize lots of what we're doing. We seem to focus, and I understand that, on the pathologies, the physical and mental pathologies of men. And that's not health, that's disease. And so I've looked for ways to try to get people to think of salutogenesis rather than pathogenesis. I'm not going to say too much more, you'll be pleased to hear, except that that emphasis on the health of men rather than on disease of men has stayed with me. And I've been lucky to work in Western Sydney in a drop-in centre for Aboriginal men at risk of suicide. And I've, of course, learned many things from that. And I would suggest to anybody who can, and that includes Derek, to drop in there and see that what they try to put in practice, our two Aboriginal colleagues there, is to deal with the causes of suicide and not just the, what I would say the endogenous, that men don't talk, men don't get in touch with their feelings, but actually to look at those things which drive men towards suicide. And I'll finish by saying that in this terrible time of COVID-19, we noticed that suicide has gone up and unemployment has gone up, underemployment too. And not to connect those two things, I think, would be very unscientific. So if we acknowledge that unemployment affects suicide, then surely, surely, surely we're going to move away from the idea that it's masculinity which is driving men, only masculinity, towards suicide, that there's exogenous factors, things which we would call the social determinants of health and the social determinants of male suicide. I should stop there before Anthony tells me I've said enough. But you get a flavor, I think, despite the accent, which I hope you get through, my origins being in Scotland, I hope you get the idea that what I'm interested in and what I continue to be interested in, and I'm very glad that Christine Morgan, who's now been appointed as Special Advisor of Suicide Prevention in our country, she began by talking not about men not talking, not about men not accessing services, not about masculinity, but about the social determinants of health, of men's health. I really think that's a wonderful way forward. Thank you.
No, thank you, John. And that focus around the social determinants of men's health, particularly in Australia, and particularly with the work of the Australian Men's Health Forum. And John was also the first chair of the Australian Men's Health Forum. I think it's been very instrumental in setting that focus for a lot of the work that's been happening in Australia. So thank you for that introduction, and also thank you for the ongoing work you're doing with men and promoting men's health. So I'd like to turn to James now, to Professor James Smith. And I first met James, it wasn't quite 20 years ago, but it must be getting close, when you were, I think, just starting on your PhD journey. So it's very exciting to welcome James, and would really love to hear a bit of introduction to you and your work and the particular focuses you've been looking at.
Yeah, not a problem. Thanks very much, Anthony, and thanks to John and Glenn for the introduction beforehand, and to the Australian Men's Health Forum for inviting me as well. That's a perfect prelude. I don't know if you can hear the barking in the background, but I've just returned from the US and I'm in home quarantine at the moment. So if you hear kids, if you hear dogs barking, planes flying over, please forgive me. I also don't have Wi-Fi at home at the moment because we have literally just returned, so I'm on my phone, so apologies if I'm not responding as quickly to chat functions and stuff. Before I start, I do want to acknowledge the Larrakia people and pay respects to elders past, present and emerging. It's been really important. I'm obviously based up in Darwin in the Northern Territory, a large Indigenous population, and much of my work has been related to Indigenous male health in the last few years. So that's a heartfelt thanks for being able to live and work on their country. I'd also like to acknowledge briefly the power and privilege that I hold as a white male in academia as well. And I think, John touched on that briefly as well, and the privilege that we do have to work with some of the most vulnerable and marginalised groups that we do. I guess I just wanted to start off to say, as many of you will know, men's health is a really eclectic field, and it's advanced tremendously over the last couple of decades. We've seen a lot more scholarship in this space, both biomedical, but also that which John just spoke about around the broader social and cultural determinants of health. And they're two aspects of the work that is really important, I think, to the work that I'm involved with. And that work has influenced research landscape and has become more interdisciplinary and transdisciplinary in focus. So we're seeing people from different disciplines coming together to work in this space more so now than ever before. In terms of my background, I've been working in this men's health space off and on, but always there at the sidelines for the last 20 years or so, and that spanned research, policy and practice contexts. I started off at the Royal Adelaide Hospital as part of a men's health initiative, spent some time with SA&NT governments in health promotion and early years spaces, and have transitioned into academia in the last 6 years, where have done work in either men's health seeking or Indigenous health, Indigenous education spaces, and alcohol and other drugs. Some of the other areas that have been of interest to me have been prostate cancer and gay men. We did some work quite a few years ago. I've always been a keen advocate in terms of men's health policy development, and have written a bit around that space, both pre and post the National Men's Health Policy here in Australia. Have been involved in health promotion as well for a long time, so I've written a bit around men's health promotion, and that's sort of aligned with some of John's work around moving and transitioning towards a greater focus on social determinants of health. And obviously Indigenous male health, and more recently sort of a broader gambit looking at boys and young men of colour. I've just spent 4 or 5 months in the US, a few weeks with Derek at his centre, so it'll be great to hear from him later on, and also a few months with Daphne Watkins at the Curtis Centre for Health Equity Research and Training as well. And I guess all of that work has had a bit of a gender lens cast over it, and has transitioned me to look more towards equity and men's health, and what can we learn in those different contexts. And really fortunate that last week we've just had signed off an agreement to be able to establish a Freemasons Centre for Male Health and Wellbeing in the Northern Territory, and we'll be working closely with our colleagues in South Australia as well. Just to finish up, a couple of things I wanted to say were, I think something that I have seen over the last 20 years is that we've built greater capacity. We've now got a critical mass of men's health scholars, both nationally and globally, many more health high degree research students, many more early career research students, and that provides us new opportunities both nationally and globally. And I want to congratulate the Australian Men's Health Forum for actually inviting some of those next generation people in as part of a panel discussion later today. And I guess what I also want to say there is that I think that that provides new opportunities for transnational research on men's health, where we're actually collaborating across national and across national borders, and hopefully that we can start to see more global research projects emerging in this space. So I'll hand it over there. Thanks very much, Anthony, and look forward to the ensuing discussion.
No, thank you, James. And I think those points are really important. And as you say, in more recent years, we've seen that growth of interdisciplinary research and people from different disciplines coming together. And like you, I look forward to hopefully more international collaborations and research, and hopefully policy with a global focus on men's health. And your question and that interest in equity, I think, is really important, and a point that I think I'd like to return to a bit later in the discussion. But now I'd like to invite John Oliffe, if Professor John Oliffe would mind saying a few words. John and I first met John actually at the 2001 Men's Health Conference, which we hosted at the University of Western Sydney in Richmond, New South Wales. And I think John was in the stage of maybe just completing a PhD or at that stage. But anyway, we've kept in touch and always sort of followed John's career as he's gone off on his great international career. So welcome back to Australia virtually, John, and please love to hear more from you and your work at the moment.
Thanks, Anthony. It's good to reconnect with a whole bunch of folks. So it's kind of, yeah, it's really nice. So I value the opportunity. Just, my land acknowledgement is that, I'm gathered on the traditional, ancestral and unceded territories of the Musqueam people, and by extension you are too, with Zoom. And so acknowledging that is really important, and just wanted to shout that one out. I was drafted in what could only be described as an academic draft. I was about 3 chapters into my PhD, and UBC gave me an opportunity that I couldn't get in Australia at that point. And so it was a 2-year deal, and it's 20 years later. And obviously a very patient crew here in Canada. Don't mind giving you time to get it right and get it wrong sometimes as well. So it's been a really interesting time. Do 3 things. Do psychosocial prostate cancer kind of research, because men tend to live a long time with prostate cancer, and so some of the things that come up for them, are more amenable to trying to deal and manage with illness and relationships. So done a lot of work there. Done some work in smoking cessation. I think I was pretty good help for Joan Batorf, who had a real interest in that area, and we've done some nice work in that space with Indigenous dads, with dads more broadly, and with men around smoking cessation in the context of pregnancy and postpartum, which was kind of a really nice relational kind of way of doing some work in gender and men's health. And probably, since about 2007, you had a fairly heavy presence in men's depression and suicidality, and that's been super interesting. And of course, those 3 things, they often intersect, smoking cessation, prostate cancer, and mental health. I mean, they're things that we disaggregate as researchers, but a lot of times they actually connect in pretty profound ways. So that's been the program of research. Just in terms of got some things going on in Australia and some things going on in Canada in terms of research, which I'm deeply grateful for. And it's great to see Kylie and Zach on Zoom here today, being connected to those next generation early career scholars in some great work with Jane Perkins. So the next session, I think, promises to be super, super interesting. So I'm really privileged to be involved in that one that Jane just got, and the team. I just throw out to get me sort of started. When I saw the questions for today, the first one about what is men's health, and the first thing I thought about was what it's not. And so I'd just say, I want to just share a couple of things around that, just to say, I don't think it's about men not living as long as women, and I don't think it's about men not going to the doctor. And the reason I think that is because it's 20 years later. And we might have started there, but we cannot afford to be in that terrain any longer. Sex research, or sex differences research, to me, we just end up in a cul-de-sac. You know, we don't get down to the nuts and bolts of it. And it actually blinds us to what John says about the soluogenic notion of about strength-based stuff, or what blokes do well. It blinds us to that because we're in a deficit model. And I don't think that's helpful. And also, it completely dilutes the health inequities. If we aggregate and just go, there's 4 years difference, and blokes don't go to the doctor, we'd miss the point. Like, we're not doing inequities. We're not really representing, you know, the vulnerable in those spaces. So anyway, just to shout that out, just to, you know, just the things that were going through my mind, because I love the questions that you posed at the front end for the session, but I immediately thought about maybe what it's not.
Thanks so much, John. And I think that question, you know, about what men's health is and isn't, is something, if we have time to, I'd really love to return to and unpick a bit further. But you also mentioned equity. And so with that in mind, it gives me, I'm really excited to be now introducing Professor Derek Griffith from Vanderbilt University. I've known the two Johns and Janes for a long time, but this is the first time that I've met Derek. And I have to say, Derek, your book is my bedtime reading at the moment, Men's Health Equity. It's not very good bedtime reading because it keeps you awake and makes me think. So it's a great book, but not for bedtime reading. So welcome, Derek. I'm so excited that you could join us for this discussion, and we'd love to hear from you and your work in men's health and yes, your work at the moment. So welcome.
Thank you so much. It really is an honor for me to be with you. Let me also start by acknowledging the traditional owners of the land where I am, the Cherokee and Chickasaw nations here in Tennessee, the elders past, present, and emerging. And again, let me say thank you to the Australian Men's Health Forum for inviting me. I'm very excited to be part of this conversation with folks whose work I've been reading and citing and teaching for a number of years. You know, John Macdonald's papers originally on, you know, a strengths-based approach to men's health policy has sort of still been one of my anchors of my men's health class that I've been teaching, you know, for a number of years. John Oliffe's work, I mean, I could just keep going on. Certainly, James, the work on men's health policy and all of your work just has really been so influential in my work. I would say that the way that I would frame sort of what I've tried to contribute to this space is to really, you might say, sort of center the margins of some of the work. So there are populations that within men's health that have not gotten the attention and the central attention that I think they've deserved in their own attention. So, you know, I tend to work on African-American and Latino men here in the States. I've done some stuff with colleagues in New Zealand on Maori men and so forth, but really thinking about how do we understand those populations for who they are, and very much from that strengths-based perspective, what are those notions and the structures that are affecting them, but also the strengths of what they're trying to bring to the table to build from a positive perspective. So I've moved away from, in my work, really focusing on masculinity and masculinities to manhood, which we found to be much more of an aspirational sort of goal that's really thinking about, from a developmental standpoint, what are the things that men are trying to achieve, and how paradoxically are there efforts to be, you know, a good father, be a good husband, to be a good provider, or contribute financially to a household, to embody these positive characteristics. How are those things adversely affecting their health, or how they're prioritizing their health? And so that's been a lot of the anchor of the practice work that I've been doing. I do a lot of behavioral interventions, largely around eating, physical activity, cancer prevention, and so forth. Some of the work sort of at higher levels would be some of the work on racism and really looking at racism through sort of an intersectional lens. So how does racism look different for men and men of color? And how do we need to understand that and really think about what does, one of the challenge with an intersectional lens has been that we tend to just blend all the pieces together without thinking about, as you're blending, what does each ingredient bring to the table? So part of what I've tried to do in my work is really to think about, well, if you're calling something race, what does that actually mean as a proxy for something? Where does gender sort of fit into there and different aspects of masculinity? Where does their age or phase of life that they're in, the kinds of things that they're aspiring to do, ethnicity, you could go on and on. But it's not just sort of blending the pieces, but really to think critically about what are the pieces that you're bringing together and why are they important and how do they fit together? So really trying to think through those pieces. The last thing I'll say is we've also done, also have led a couple of times now, we're in the process of doing the third for me, the Tennessee Men's Health Report Card that I know has been sort of influential in trying to really frame or reframe how we present data to key people in our communities so that it's, usually it's not that we're analyzing new data, it's not we're, getting or collecting new data, but the way that it's presented, the way that it's packaged, the way that it's made accessible has not rendered it terribly useful for stakeholders, for people in the community, advocates, and so forth. And so we've tried to repackage that by using things like infographics, brief videos, and so forth to really think about those kinds of issues. And so I was very fortunate to go to Ireland in December. They were doing some work about an Irish men's health report card to kind of build on some of their work. I know you've done a version of that in Australia, and so it's very exciting to see that come. So it's just, that's been sort of a big part of sort of what I've tried to do in terms of presenting and sharing and thinking about strategies from that standpoint as well. So thank you.
That's wonderful. Thank you so much. Not just for that introduction, Derek, but for the work and for that movement that you've been involved with around bringing an intersectional lens into our understanding of men's health. I had originally suggested some questions for the panel, but given the discussion we've just had, there's a couple of points here that I think I'd actually like to return to and pick up on, because I suppose one of the themes that's been running, there's been a few themes that I think has been running through all the introductions and the work that people are involved in. One's obviously around equity that I'd like to look at. That and the idea of masculinity and what how that's traditionally been defined by the academy, and then Derek's work around manhood and framing of manhood. I'd like to spend a bit of time looking at that and asking the panelists what they more feel about that, and with the focus on the strengths-based approach, because I suspect they're linked. And I might return to John Macdonald and ask John, particularly around that manhood, masculinity discussion, just any reflections or thoughts you might have around that.
Very kind of you to let me speak on that, Anthony. Yes, I must admit I've thought a lot around that, partly because I think we didn't start Men's Health in a vacuum. We started talking more seriously about men's health in a context. One of the contexts, and I'm saying this with great respect, one of the contexts is feminism and the rise of the very understandable movement of women who realize that in many, many circumstances, especially socially, women are disadvantaged. And the movement towards that has meant for me that men's health, in a sense, came to light in this time with some very positive effect, that men would therefore be obliged to look at equity between genders. And now, as maybe as that has been suggested by our colleagues, to look at between men as well. However, that context of femininity, of feminism, means that masculinity for me, and please, I'm open to contradiction here, masculinity in academia had a very negative connotation. It was very hard to, and still is in Australia, I have to say, both in policy makers and in popular media and discourse, to say that there's something positive about masculinity. And that I find is very sad. I'm very pleased to hear other movements away from that. But one word about that is I make genuine acknowledgement of Professor Connell, who did lots of the first work in this area of masculinity. And she speaks about configurations of practice which men can call on in situations. And those configurations she sees as competitiveness, aggression, violence. And it's indeed, those are factors that, as we embrace the contradictions of our situation, that we mustn't run away from. However, I would like to say, finally, there are other configurations of practice in men, which are caring, protectiveness, the desire to support people, etc. Those are other configurations of practice which did not feature, and still often do not feature, in academia and in popular understanding of masculinity. So I tried to write about that, and maybe not very successfully, but I still believe that there's a lot of mileage for us to follow in terms of looking at what's positive in men and not just what's potentially negative.
Thanks, John. Derek, I'd be interested to know if the points that John's raising there, if they, your reflections on that, and how you think, or do you think that the concept of manhood as you're using it and defining it is a useful way through this discussion?
I've got to say first, I hope so. I very much, I think John's, point is exactly sort of where I came to this work, which is, I started I'll try to make this quick. So I started doing this work. I was originally trying to do this in the context of interventions to try to address, men's unhealthy behavior as it related to cancer. So eating, physical activity, those kind of things. And how do you promote those? And wanted to use measures that would help us to tailor information to men by getting their sense of their attitudes and beliefs. What I found immediately was that the measures that we had out there didn't reflect when I talked to men, what they were talking about and how they thought about what they were actually trying to do as men. And so this concept of manhood, and actually it was originally sort of role strain, where their efforts to try to fulfill different kinds of positive roles as fathers, as husbands, protectors, as caring for families, showing these positive attributes were nowhere to be found in the measures that we had at the time that were largely coming out of psychology. And so I was kind of stuck in this space of not having any language to do that. And what I thought was really different was that there seemed to be, the role strain piece actually added this age component to it. And so if you think about the messages that males are getting, when you're a young boy and so forth, that's very different than the expectations and aspirations you have as an adult male. So I think the idea of adding, and I think part of the challenge for me has been this idea of like toxic masculinity is certainly still all the rage. There's still all the things about now COVID and, you know, how toxic masculinity explains all the things that men are not doing in COVID and so forth too. But I think this idea of manhood and what are the positive things that men are aspiring to do that are actually getting in the way of their prioritizing their own physical health is something that we have to sort of grapple with. And if you think about the kinds of things that, you know, they're trying to do, they're usually trying to do good things. It's just that that gets in the way of trying to promote their health simultaneously. So I just have found it to be a much more useful way of framing those kinds of issues that are consistent with the way that they described it qualitatively.
Thank you, Derek. I think that's that work is giving all of us a very useful framework as we work with men, and as John says, it's a framework where we can embrace the contradictions. John Oliffe, I'm just wondering, you mentioned the term strengths-based. I think we've all sort of tried working in a strengths-based approach, and I just would be very interested in your reflections around between what Derek and John have said, where you see a strengths-based approach fitting into or informed by these sort of conceptual ideas around manhood and masculinity.
Yes, sure. So this is like being in a lolly shop. This is so many really things I want to pick up on, and so anyway,
you're next, James. I promise you're next. I can see James waving his hand. Yep. Sorry, John.
Just a surge of consciousness as it goes, but I'll pick up on a couple of points. I still think Connell's stuff holds up. I think that even the plurality of masculinities give us a shot at inequities. And I think that was a key moment, right? Because we got away from this biologically pre-wired, this is how blokes are, you know, and it's going to be bad. So we did get away from that. The blind spots for me in the model or in the framework of Connell's are around the marginalised and subordinate and around some of the complicit. And so, you know, one of the things I think about a lot these days, I go, well, okay, so if subordinate is about being out as a sexual minority, being a man of colour, and then you've got this marginality that happens on top of that, but it's not just in those particular situations. Marginality can happen to anyone in any particular space. Like, you know, it does happen to women, to men. And so I think we've got a little bit of work to do there to unpack some of that. And the other bits that I've been thinking about more recently, and we've been writing a little bit about, and Zach's on one of these as well, is around values, masculine values. And we've talked about norms, and we've talked about gender ideals and masculine ideals, and hegemony has gotten the major bandwidth. But maybe what we really needed to be kind of starting to focus on was, what do they value? Because if you know what they value, then there might be an opportunity to sort of build in some of those strengths in kind of authentic, homespun ways. And again, I'm not pollyannaing, you know, blokes' behaviours and the things we get wrong, but I'm just saying that, you know, if you know what someone values, it's a lot easier to talk about what might get better, you know, what you might adjust. So just to say, I don't know if that even answers your question. The sex differences piece that I made reference to is it just, difference doesn't help us. Diversity helps us, you know, because then we build and we tailor. But the one thing I'd say about biology, it gets misrepresented a lot as static. And there is an intersection of sex and gender that we're in a prime position to grab hold of in men's health, and it's a prime opportunity to start to have those really awkward language conversations about how sex and gender feature in a lot of what happens for guys.
No, thanks, John. I think you were wondering if that answers the question. It answered some of the question and opened up a whole lot of new questions. So That's what I think academics are very good at doing. So thank you. And it does, yes, I think we all feel like we're kids in candy shops with this particular discussion. So James, I know you were keen to make a observation here around, yes, so please go for it.
Yeah. Can't agree more with what John just said in terms of feeling like a kid in a lolly shop. I think there were two main points that I wanted to make that sort of stem to the discussion that we've had so far. One is going back to something that John Oliffe mentioned when he spoke around what men's health isn't. And I think that there's been a significant evolution in thought over the last 20 years, and that we need to acknowledge that and really listen to what's been said. John Macdonald's spoken a lot about social determinants of health and salutogenesis and a strengths-based approach. John's spearheaded a lot of work around the plurality of masculinities and thinking differently in that space. And then you've got work of Derek's, which is really starting to look at the intersections with other aspects of life, other than just thinking of things purely from a gender lens. And I think that evolution of thought is incredibly important to where men's health is going to in the future. And I think that can help drive that equity narrative in the way that the others have said. What I think, though, is a major challenge from a men's health research perspective is changing that narrative within policy and practice contexts. And I think this is really important because the people that tend to revert back to those hegemonic or toxic masculinity discussion points that go back to a deficit rather than a strength-based approach. And often, I should say, that's done unintentionally, I think, but sometimes it is. And you'll have a politician that will come out and will say, men don't go to the doctor, we need to fix this. We need to use our evidence, all the research that has been done over the last couple of decades, to change that narrative in policy and practice spaces. We need to challenge masculine stereotypes when they're used in health promotion work. We need to think differently about what some of the policy levers are. And I, again, would say that the equity and focus on marginalised and vulnerable populations is really important there. So I'll call it quits there so that we can open it up to further discussion, but hopefully that's sort of given a bit of an overview on where I'm thinking in terms of what's been discussed so far.
James, thanks for that. And actually, that's a perfect pivot into the next thing that I wanted to pick up on, was that intersection around policy and research, because I think you're absolutely right. I mean, we do know that, policy is often, what do they say, policy is 10 or 20 years behind where research is. And everyone on, all of the panelists have been very much involved in working in policy settings at different levels and with different governments. And I'd just be interested to hear people's reflection on that. So I might ask Derek, I'm really interested in the work with the Tennessee Men's report card and some of the policy implications on that, and your reflections on bringing good research evidence into policy.
Yeah, I mean, the report card, it's been interesting to do the dance with the report card, because it is speaking to an audience that largely has exactly what James was describing, these attitudes and beliefs about men. And so if we don't engage those, then we're sort of not seen as being credible or not seen as really being serious. And so we have to sort of engage them, address their concerns, but then figure out, okay, yes, that's important and relevant. It's not quite the real story, but here's the way that we need to think about it sort of going forward. And so part of the dance with the report card is not just sort of presenting the data, because it's very limited. I mean, it's mortality data, it's self-reported behavioral data. And so it doesn't really give us the nuance that sort of the other things do. what I think it's given us the platform to do, and the reason I think of it more, or talk about it more, as ideally wanting to have it as sort of a launching pad for a campaign around men's health. And so if you think about the kinds of things that you're wanting to do with that information, is to say, okay, here are the data that we have, and here are the health problems that we're seeing. And yes, there's some things that we need to change. But what do we need to do going forward to change those things? We have to have a narrative that is going to build from the other research that's not explicitly included in the report card. So to think about the policies and practice, the strengths and so forth, that's why we've added, the pyramid from Thomas Frieden, which is one of the former directors of one of our national Centers for Disease Control and Prevention. But he has sort of this health impact pyramid that sort of has different layers and levels of thinking about where and how to intervene to think about where and how to intervene with men at different levels, but also thinking about the messaging that we've tried to do that by bringing in some more of that's where the video pieces have come in to help, reframe how do men talk about these issues so that we can get both sides of it, because the quantitative data don't really allow us to see the humanity in the men of what they're dealing with. It just sort of flattens it a lot of times. So I think that's been a key part of what we're trying to do with the report card, is bring the humanity in the men back to the data as opposed to just looking at it as numbers.
Thanks, Derek. And I think that's one of the big, personally, I feel with research generally and policy generally, that bringing the humanity back into it is one of the big challenges. John Macdonald, you've been very involved with helping shape the Australia's national men's health policy, and also John and I did some work around trying to influence our state of New South Wales men's health policies and frameworks. So very keen on your reflections about this discussion.
That's very kind. But could I just say quickly two things? I may have to go very soon to see the surgeon who did this terrible work on my shoulder. But listening to Derek there was very inspiring for me. And for this reason, some years ago, I was involved at a conference actually in Palestine with the editor of The Lancet. And it's about 7 years ago. And we came to an agreement that we would have a series in The Lancet on men's health. And I tried to get that together in an international way and failed. And one of the reasons I failed, apart from my own ineptitude, was what Derek has pointed out about lots of the data was epidemiological, was about numbers and figures, and we want more than that. And I'm just wondering if, as part of a result of this initiative of AMHF, if anybody feels that we could pick up in that again, and actually have in the Lancet a series on men's health, boys and men's health, which deals with social determinants as well, inequity, and diversity, intersectionality, but that would be wonderful. But one of the difficulties was indeed the ones that Derek said, mentioned this idea that lots of the data is biological or is epidemiological and doesn't look at what it's like, what health is about. It's describing disease. So if anybody wants to pick up on that, that would be wonderful. It would give a new lease of life to that possible initiative with the Lancet. And in parentheses, before I go, I'd like to say nobody's mentioned, and I should have mentioned, AMSA, Australian Men's Shed Association. Talking of the social determinants of health, here in Australia, we have over 1,000 sheds, and in Ireland and some other countries too, the States even, and in Iceland 3, where men get together to support one another. And definitely, I'm a patron of that movement. It's about men's health and not just about disease. And once we've got that idea that institutions like that, which bring men together and support them, and where they can support one another, health, that's tremendous advancement, which I think should be acknowledged. But just to go back to what I was saying about the Lancet, if anybody picks up on, if that echoes something in someone's head, the need for and the possibility of doing something about, policy and practice in men's health, which is not just biological and epidemiological, but as an international perspective on moving forward I would be thrilled to be part of that.
Okay, thank you, John. And I think maybe we can have a chat to Glenn about ways that Australian Men's Health Forum might help coordinate and put interested people together about that. And John, one of the things that I recall when the first Australian National Men's Health Policy was being drafted, and like all policy documents, it's an imperfect document, and I think its legacy, it didn't leave the legacy we'd hoped it would. But one of the things that I think made it a strong document was actually the process of going around, and instead of a document being written by policy experts in Canberra or academics, at our desks in universities, part of what informed the policy was a series of going around the country and listening to what local men had to say. And yes, health policy experts, and yes, academics, did play a role in informing its development. But I think the strength that policy has actually came from that direct involvement of men talking about their issues, their concerns, and areas where they thought things were going well. So,
for me, it's very exciting. You should say that, Anthony. And I do remember going around. Of course, we couldn't do the whole country, but they appointed what they called 12 men's health ambassadors, including McAdams, so I hope you will listen to it later on. And we went around all kinds of places, and we listened to all kinds of groups. Of course, we didn't get everywhere, and we didn't listen to everybody. But you're right. I think that idea, what made that 2010 policy different, for all its faults, it was based not first of all in academia and academics talking about masculinity or why men don't, etc., but what men themselves wanted. I thought that was quite exciting. And to be honest, I feel that was a step forward. And maybe we should admit that there's 3 steps forward and maybe 2 steps backward since. But still, let's hope that we can go in that direction. And anything that you can do in your work, talking of consumers, forces us to listen to men and some kind of participatory action research, which I think we've been a little bit involved in the shed in Mount Druitt. I think anything in that direction seems to me to be enormously positive.
Thanks, John. And for people who don't know, my day job is as CEO of Health Consumers New South Wales, which is an NGO that's dedicated to patients and people who use health services having an active role in the design of health services and their governance. And we're increasingly being asked to involve patients in the design of health research as co-researchers. John Oliffe, I was wondering if you had any reflections around that research policy intersection that you'd like to reflect on.
It's so interesting from an outsider point of view. I think Australia's done really well. So yeah, everything's relative, right? We don't have a men's health policy here in Canada, nor I wouldn't anticipate that we will have one. We have enormous trouble naming suicide as a men's health issue. It's a tough go in the policy world. So that you did get some ink on the page, and it might not have been perfect. There was also some money for men's sheds. There were government money, and if you've got policy with teeth, I'd give you a bit of a cheer up, because it beats getting grants, year to year to keep things going on intervention. So, I think you've done really well in many ways. And here, I'm not whining. We've had lots of good programs and successes and things like that. But policy is, it's just not something we've been able to negotiate. And maybe I think one of the cheer up notes about policy in Australia is when I look around the folks who are on this and some of the great talent you've got in Oz, I actually think it's hugely to do with how well the policies have gone. Like that there was a discourse. So, you know, not to Pollyanna, but I reckon you've done very, very well. You got rising stars. You know, you're getting people from Canada. Christine Cappucciano is on the bill today, does great work. You know, so you actually recruit to a space where some good work's being done, and policy with teeth has a way of attracting talent. So just to say.
No, thanks, John. And I think it is. It's always helpful to have an outside perspective to, I suppose, let us see how, not just how far we have come, but you know, the strengths of actually doing men's health in Australia. I did, before I open up some of the discussions and issues that have been raised from the audience through the chat function, and I can see people have put in a few examples of policies and policy areas where people feel that the deficit view of men and masculinity prevail. I did want to try and have a discussion around, I suppose, what's another huge topic, and that's around equity in men's health research. And I think in this time when we're reminded of the importance of Black Lives Matter, that this is, you know, a really crucial conversation and a role where men and men's health, you know, has a very there's an important role for us to step up and have this conversation, because it is one of those areas where all of those contradictions about men and men's health and the positive and negatives are sort of coming to play. And Derek, not just because of your research, but also because, I mean, the very title of the book that you've edited is called Men's Health Equity. I'd be really interested to hear from you around, I suppose, what you see some of the key issues and challenges are for us as men's health researchers in exploring this concept of equity.
Yeah, I mean, I think it's a wonderful question. I would start with kind of where John Oliffe just sort of left off, that there are a number of topics that are very difficult to get people to see as men's health issues, or to see how, you know, gender plays a key role in the experience of it beyond just, you know, that there's a factor into it. So, you know, if you think about the issue of legal intervention, or that's the technical term from our government standpoint of essentially police-involved killings of particular populations, how overwhelmingly that is involving men. And when we think about issues of things like racism and so forth, what's also interesting is when you talk to men about that, they usually don't think of it as gendered. They think of it as just, you know, racism, and it's really about that aspect of their identity, not realizing that part of the tension that they're experiencing is the social dimension of the body that they're embodying, and sort of the characteristics that are coming with how people are seeing them as gender beings, not just as, you know, a person with particularly dark skin and particular types of features. So I think that's an important part of this conversation, that it's difficult from sort of the individual standpoint sometimes to name those factors. It's difficult to feel, you know, within the field for equity for us to look at the heterogeneity among men and to be okay with, you know, looking at individual groups and seeing what do they have to offer our understanding of other groups. And so I think one of the things that we were able to do, just as a concrete example, is one of the collaborations I had with a colleague in New Zealand was actually looking at some of the work that I had done on role strain with African-American men and how it was a barrier to physical activity. And he was finding the same thing in New Zealand with Maori men, but otherwise didn't have language and research to show well, why are they not doing these things? And it was a very easy sort of comparison or application of what we found, the principles of what we found that could apply to that particular group. So I think it's also what James was talking about earlier. There are lots of these opportunities to learn from one another and to bring equity more centrally to the field. And I think that's going to strengthen where we're able to go, because we're still fighting a lot of the tensions of, well, men are already advantaged in our society. They don't face sex. We don't face sexism and so forth. We still have a very heteronormative society and so forth, all of these different things that are very true. So it's hard for people to sort of buy this idea that we need to focus on men. And so I think the ways to get at that sometimes are to do it through men who are in some ways defined as marginalized, subordinated, and so forth. And by bringing them more centrally to the conversation, and what can we learn from those men that can apply to others?
Thanks, Derek. I think that's quite insightful and something that I know for a long time, it actually mirrors, I think, conversations we had at our research centre around the importance on focusing on particular groups of men and their experiences as a way to show and highlight the importance of, why we should be researching, men's health at all. And James, I'm curious if you could maybe give us some reflections on that, and particularly what you think, around this discussion around equity and those issues that Derek's raised. What do you think that could mean in an Australian context around the research that's happening here, or perhaps needs to happen here in men's health?
Yeah. I'll answer it from a few different perspectives, if that's okay. One is, within the men's health landscape, what we've often done is equated equity to gender equity, and it's because we've cast that gender lens. And actually what we're talking about now is something that's much broader. It's around broader health and social inequities that may relate to gender, but that may not relate to gender. And that's really important to move away from what John Oliffe was talking about before in terms of that binary between men's and women's health, where we've often come at that from a very explicit gender discourse, a gender equity discourse. And I think that's important because many of our global policies focus on the gender equity aspect. We need to start to place men and privilege men's voices in that broader health and social inequities space. So I guess I wanted to start off there. In terms of where we can learn with some of work that's happening overseas, including that work of Derek's, is, I've had a particular interest in Indigenous male health, and particularly young Indigenous males in recent times. And when we start to unpack things from more of a social determinants perspective, where we start to look at health and social inequities, we start to see patterns that can be very similar across vulnerable and marginalised groups. And COVID-19 has been a great example of showing us where some of those health and social inequities lie. And I think that as a men's health research community, we can use that to advance work in this space. So, for example, the Fulbright that I've just been involved with, where I've visited Derek's Centre and Daphne Watkins Centre at the University of Vanderbilt Uni and University of Michigan, respectively, has focused on boys and young men of colour. And really what I've been interested in is what's happening in the US in terms of Native American boys and young men, African American boys and young men, and what are some of the take-home lessons that may be synergistic with Aboriginal and Torres Strait Islander male health back here in Australia. I'm not saying that everything is the same. What I'm saying is that there are opportunities to learn in that broader global context, and to share stories and to learn from each other around what may or may not work and how we can reduce inequities for these vulnerable and marginalised groups. So obviously for me, it's been an unprecedented time, both with COVID, but also with the anti-racism protesting that's been going on, again, not just in the US, but nationally. So that's provided a platform for for us to actually dig deeper into this space, to have that as part of the men's health research narrative in a stronger way than what we've got at the moment. So, you know, I think that there's lots of really positive work that can come to fruition over the next few years, and I'm really looking forward to that. And I do think that we need that equity lens built into policy and practice as best as we can as well. And I agree, and I'm very thankful for a lot of the work that John Macdonald's done in terms of driving a very positive men's health, a very positive focus in the men's health policy work in Australia. The social determinants stuff of the 2010 policy, really good. I would say that the current policy has probably taken a slight step backwards in terms of it being a slightly more behaviourally focused. Yeah. But both of those policies have focused on equity within them, and they're things that we need to continue to utilise in the men's health research space, and to build that evidence base that can strengthen the policy and obviously the health and wellbeing outcomes longer term. I'll leave it there for the moment.
No, thanks, James. And so one of the things in this discussion that I must admit I feel a bit uncomfortable with is the idea of, and I don't think anyone's proposing this completely, but the idea of actually moving away from discussions around, you know, different health outcomes and differences that we're seeing between men and women, and it could be, you know, men and women across populations, because I still feel that while I support the ideas that are being and the work that's been done here, I still feel that there's issues such as men's access to services, for example, where using comparisons between men and women and health outcomes and health behaviour is still important and still needed to drive change. And John Oliffe was the first one in this conversation to bring that up. So I would like to push back at that a little bit and just sort of get your views on that, if we could expand that idea a bit more.
Sure. So an example would be, so Zach's talking in the next session about services, but he's talking really about what psychology can do for men in terms of suicide prevention. You know, so it's tailored. You don't have to make the case that guys don't arrive in practice as often as women to have work like Zach's happen. So it's at the front end of a paper when you're reporting out guys and outcomes, whether it be gender or sex based, you don't need to start with it's different to women, because what we're trying to do is advance the field to say we need tailored services. We know we can't just keep shouting at guys to go to the doctor, because we're a long way down the track and they're not going. But, you know, one of the key things is too, guys do go and then they're lost to follow-up. So a little tidbit is just to say, you know, 60% of the guys who suicide in Canada, they've been in the healthcare system in the last 12 months. So then it's like, well, clearly the one-size-fits-all isn't fitting guys. So my point is we don't need to belabor the difference. We just need to get into the tailored pieces to better accommodate those guys. And these are structural issues as well, because we've got community-based things that are doing very well. You mentioned men's sheds, that's one, but there's a myriad that are buddied up to the social determinants of health, and the same with e-health. You know, there's some good traction in those spaces. So again, it's like it's just tailored, and so that's why I'd bypass that. I don't think we need to make the case. I think the case is if guys are suiciding, you know, in high rates, then we've got to get services that speak to guys that can, you know, help with that. Cardiovascular disease, same. These things are all amenable to prevention.
Yeah.
Thanks, John. Derek, and then I'll go to John Macdonald. Yeah.
Oh, sorry. Yeah, I think there's sort of a both and potentially here of, I think it can be useful to utilize that comparison to identify the problem. Where I would diverge from that is saying that identifying how to intervene is not going to be useful to look at that as the comparison for that purpose. I think that when you're trying to figure out how to intervene, you have to look at it from the population and start with what their values, their perspective, their beliefs, how they're seeing the world, and what are the things you need to build on from men to get men to do better, but not as a comparison to women. So I think it's useful. It's kind of in the US context, it's kind of the difference between minority health and health disparities. Disparities are the comparison to another group that says, okay, who's doing worse and whose health do we need to focus on? Minority health is the idea that once you've identified the group that's doing worse, what are the strengths and the anchors and the things that you can build from for that group to get them to do better? Not necessarily relative to the other group, but just that can get them to do better. So it's the contextualizing from that standpoint that's really useful.
Thanks, Derek. And John Macdonald, do you have any reflections or anything you'd like to add on this discussion?
Oh gosh, I think in some ways I've shot my bow. People know that I talk about salutogenesis and the fact that we need another way to look at masculinity to see some positive dimension to it. But no, I don't think I've very much, actually, the truth is I was about to message everybody that I'm about to withdraw, partly because the nurse is coming and to see my shoulder, and then I'm off to see the surgeon who did this work on my shoulder a couple of weeks ago. But no, I have to say how heartened I am by this discussion. I really, to be honest, I felt maybe that those perspectives we had maybe 10 years ago had become lost, and that's obviously not the case. People are still pushing forward and trying to do, I would say, I've just said to Nick, and Nick was suggesting that maybe what about patriarchy, if I understood him? And indeed, I don't want us to say that we should ignore the problems we have, or I do think we should, as I began by saying, embrace our contradictions. We are all part of patriarchy. We are all part, most of us, of racial discrimination. We are all part of gender and class discrimination here in Australia and elsewhere. That's who we are. And unless we're upfront with that, we're not going to be able to, unless we address our own social determinants, we're not going to be able to address those of other people. And that shouldn't be a hindering for us. It should be a stepping stone forward. With that, I'm going to have to stop because this is kind of show. Someone said, I think Zach said, I'm wearing a Gandalf cloak. Sorry, it's to try and keep my shoulder warm as I go forward today into therapy and things like that. But I want to thank everybody for this and for giving me a chance to speak. So, and you, Anthony, thank you for chairing this, but I'm bowing out at this point. I may try to come in again and listen later on. Thank you.
Thank you, John. And your commitment to finding out about men's experience in health services, they may be going above and beyond, but thank you for joining in, and we all wish you the best and a speedy recovery.
It's very kind. Thank you, everybody. Thank you, Anthony. Bye-bye.
So we're fast reaching the end of our time for what's been a really fascinating discussion, and the discussion that has been happening not just with our panelists, but also the discussion that's been happening in the chat room between everybody. So thank you all so much for adding to that. And we've got some wonderful examples that people are bringing up around, not just, as I said before, examples of where policy is falling back to old deficit-based models, but also examples of services that are engaging people. There's been a lot of discussion around older men and positive services for older men. And one of the, I think the areas that perhaps is very challenging, and I hesitate to bring it up, not because it's controversial, but just because we have very little time, is a couple of people have mentioned the way in which men and masculinities are framed in our understanding around work with domestic violence and family violence. A really interesting and important issue, and again, maybe something in the time that we've got left that we don't have time to go into in detail. What I would like to do, though, is acknowledging all of those discussions, just ask for a final comment from our speakers. Unless, Glenn, there's anything you would like to draw particular attention to or ask at this stage? No, it's a no. Okay. So what I might do in the few minutes that we've got left is invite our speakers for a closing comment. Please keep the conversations going, and I'd also invite people to add any links or web links to services or research or things that they'd like us all to know about, because I know that chat is being saved, and we're already finding out some amazing work that's going on through this chat and the chat that's happened in other sessions. So I'll ask James for your closing observations, then John, and finish with Derek. So James. Yeah,
not a problem. I guess to reiterate what you just said, Anthony, is to keep the conversations going. I think having a space to be able to have these discussions, to engage in conversations. If COVID's taught us anything, it's that we can do things via webinar and have these face-to-face conversations in a virtual way across huge geographical distances. So I'd really encourage people to do that. And I guess the other thing I was going to say, to extend on some of the discussion around equity in men's health, is to let people know that Derek has been working really hard on guest editing a couple of issues that sort of fit within that space, one for the American Journal of Men's Health and one for the International Journal of Men's Social and Community Health. And 20 years ago, those journals didn't exist, and they do now, and let's use them, engage with the content. For those that are research, publish in those spaces. And publish in domestic journals as well. I'm Editor-in-Chief of Health Promotion Journal of Australia at the moment, and I've really noticed an increase in submissions relating to men's health in recent times, which is absolutely great to see. So the more we invest in this space, the more we learn, and let's keep that happening. And I'll stop there and hand it over to John.
No, thanks, James. And of course, yes, the importance of publishing can't be understated, because one of the things that I felt 15 years ago was working in this space and feeling the frustration when medical research or policy would reach for the masculinities discourse as an explanation for men's health, was the realization that when people outside the area go looking for an explanation, they can only find what's there and what's published. So, and also those journals that James mentioned are really important. Please, of course, publish in them. And I'm part of the editorial group for the International Journal of Social and, help me, James, with the title. Isn't that terrible? Social and Community.
Journal of Men's Social and Community Health.
That's the one. And as important as they are, I think it's also important that we work to get articles on men's health into other journals. We read the men's health journals, but if we, publish in journals around older people, younger people, specific disease journals, then we're also getting the message out to a new audience as well. John, I value your sort of final reflections.
Yeah, just a couple of points that you mentioned. IPV is preventable. And so we need to do better work with guys in terms of how they get relationships and how they maintain relationships. When those relationships are ending, we need to have better services to help them work through that, because a lot of relationships end. You know, so again, it's trying to sort of, I think there's some preventable moments there, just say. The other thing, just to close, we didn't really get into it, but you know, there's a lot of great community-based programs that are yearning for empirical evaluation, and I think that, you know, it's incumbent on us all to really build in, you know, a formal evaluation at the front end of building these things and launching them. And even when we pilot them, something that's got to go beyond acceptability. I think we need a little bit more evidence, and it satiates, you know, donors, funders, and it helps sustain some of these things, because there's a lot of tumbleweeds going down, you know, programs that were great but just couldn't sustain. And one of the things that hurts those ones is that we just don't have the evidence. We think it works, we know it works, but we can't quite, you know, assure the people that have got the deep pockets that it's worth investing in. So I just leave it, you know, a couple of random.
Not random at all, John. Thank you very much. And I think it's a frustration for all of us, particularly when you get short-term funding. It's just about rolling out a project, and you know, the difficulty of building good evaluation into that. But it's so important. There are many things that I'd hope that we'd be able to cover in this conversation today, and we've gone in different but exciting directions. So thank goodness we've got a whole day talking about men's health research. Derek, if you would like to sort of end off the session with your sort of final reflections and thoughts.
Well, thank you, first of all. I mean, I think this has been an amazing conversation, and I'm glad to see that this work is continuing. I'm very excited about, you know, the folks that you've been able to pull together. Some of the folks that I know they're on, Zach Ziegler, and others that are on the, you know, that are watching this or participating in it and are going to participate in the work going forward. The two things I would just say to reiterate some of the things that we've talked about thus far, I would make a strong case for qualitative research, because I think one of the things that, whether it's the work of Steve Robertson, John, and others, hearing the voices of men and how they're actually thinking about these issues has been really fundamental to shaping how we can think about these narratives. And so one of the things that's going to be important to do is to continue to hear those voices and build from that. The second thing is I would make a plug for interventions at whatever level, in whatever space that you actually see as appropriate. There's nothing more humbling than trying to think that you understand something and then trying to put it in place and then watching it fall flat on its face because you didn't understand it as well as you thought you did. So I think it's really important to understand, you know, to do that sort of dialectical back and forth between trying something, practicing it, seeing what works, watching it fail in some parts, and then trying to do it again and refining that process, whether it's from a policy standpoint, you know, a hospital system or some public health system, community-based organizations and what have you. But that kind of action research and using that to inform how we move forward, I think is going to continue to be really important. So thank you.
Thank you so much, Derek. I got so much out of what you just said there, and the importance of approaching our work with some humility and knowing that we may not know all the answers, and that the best starting point is actually with men themselves on the ground. I think is something I'll definitely sort of take away from that. So thank you all so much for being part of this. Thank Professor John Macdonald, who's had to leave, Professor James Smith, Professor John Oliffe, and Professor Derek Griffith. Thank you so much for your time and your insights.